Hi, everybody, and welcome to our module on antifungal drugs. I've listed on this slide the names of the antifungal drugs that are commonly used and that you need to know for step one. But hi, everybody, and welcome to our module.
ரொம்ப சாப்பிட்டா மோண்டுக்கு தரும் 3 வெட்டு மட்டும்.
Module on fungal pneumonia. Since this is our first module on fungi, let's talk about a few basics of what fungi are. So first of all, you need to know that fungi cells are eukaryotes. This means they have a nucleus, they have intracellular organelles, and they're very different from bacteria. Bacteria are prokaryotes. They're a much more primitive form of life. They lack a nucleus and they lack internal organelles. When fungi are single-celled organisms, we call them a yeast. And some of you may know that baker's yeast is used in bread. It releases carbon dioxide, and this is what makes bread fluffy and light. When fungi form multicellular structures, we call them either filamentous molds, or you may know mushrooms are fungi that grow out of the ground to release spores so that more fungi can grow. And we say that a fungi is dimorphic when it can exist either as a single-celled yeast or as a filamentous mold. Ones that can only exist in one form are called monomorphic. Fungi like to form structures called hyphae. These are long branches, and this is a picture of some of them down here in the bottom left. I think of them like branches of a tree. Sometimes the hyphae are one long cell, but often they're divided into multiple cells by structures called septa. These are called septate hyphae when the hyphae has little lines separating one cell from another. When multiple hyphae are grouped together, we call them a mycelium. And then another important term to understand is that of clanidia or spores. These are like seeds that the fungi release to form more fungi. And often the conidia are formed at the ends of hyphae in a structure called a conidiophore. And this is a picture of a conidiophore right here. You can see that it's got lots of little dots on it. Those are little spores that the fungi is ready to release to grow and form more fungi. So to keep the fungal infection straight in your mind, I recommend you group them into three categories. The first category are the fungal pneumonias, which we'll talk about in this module. They only occur in specific geographic areas, and knowing the geography of where the disease occurs is very important for the diagnosis. We'll talk about histoplasmosis and blastomycosis and coccidiomycosis all in this module. There are the skin fungal infections like tinea versicolor and tinea pedis, which is athlete's foot, and also sporothrix, which is an infection that you can get when you're gardening. We'll talk about that in another module. And finally, there are the opportunistic infections, tinnitus. We'll talk about histoplasmosis and blastomycosis. Only occur in specific geographic areas, and knowing the geography of where the disease occurs is very important for the diagnosis. We'll talk about histoplasmosis and blastomycosis and coccidiomycosis all in this module. There are the skin fungal infections like tinea versicolor and tinea pedis, which is athlete's foot, and also sporothrix, which is an infection that you can get when you're gardening. We'll talk about that in another module. And finally, there are the opportunistic infections. These are like Candida and Aspergillus and Cryptococcus and mucormycosis, also pneumocystis. These only happen to people in certain immunodepressed or vulnerable states. So there are four fungal pneumonias you need to know about. These are histoplasmosis, blastomycosis, coccidiomycosis, and paracoccidiomycosis. And they can all cause pneumonia, but they each have some unique features that you need to know about so you can recognize them in board questions. First, let's talk about some key common features that all of these fungal pneumonia infections share. First of all of these fungi can cause pneumonia, but they can also disseminate and cause systemic disease. And they usually disseminate in people with HIV/AIDS or other, all cause pneumonia, but they each have some unique features that you need to know about so you can recognize them in board questions. First, let's talk about some key common features that all of these fungal pneumonia infections share. First of all of these fungi can cause pneumonia, but they can also disseminate and cause systemic disease. And they usually disseminate in people with HIV/AIDS or other immunosuppressed states. All of these fungi are dimorphic, meaning they can be molds or yeast, except for coccidiomycosis, which we'll talk about in a minute. Out in nature where it's colder, these form molds. So you can just remember they're molds when it's cold. But when they get inside the body and they get warmed up, they all form yeast. So remember, yeasts are single-celled organisms. So you're never going to see hyphae on a biopsy of any of these pneumonia because they are all small single-celled yeast inside the body. All of these fungi cause infection from inhaling the fungus itself, not person-to-person spread. So if someone presents with a fungal pneumonia, they didn't catch it from their friend, they inhaled it from out in nature. Another key thing to know, especially for step one, is that all of these fungal pneumonias can cause granulomatous inflammation, and they are potential mimics of tuberculosis because, as you know, tuberculosis also causes lung disease and forms granulomas. And the treatment for all of these pneumonias is the same. Mild disease is treated with the azoles like fluconazole or itraconazole, and severe or systemic disease is treated with amphotericin B. So let's pause here and review the causes of granulomatous infection. So most people know that tuberculosis and leprosy can cause granulomas because those are mycobacteria. But the tricky ones are the remainder on this list. So the fungal pneumonias, like we'll talk about in this module, can all form granulomas. Bartonella, which causes cat scratch disease, and Brucella, which causes brucellosis. These are both zoonotic infections, and they can cause granulomas. Infants who get listeria from their mother can get a condition called granulomatosis infantiseptica, and it's got granuloma in the name, so that can help you remember that the baby will have lots of granulomas. Schistosomiasis, which is a helminth or worm infection, causes granulomas. And finally, in syphilis, the gummas that people get are granulomas. So in terms of USMLE Step 1 questions, all of the fungal pneumonia questions are going to have two distinct clues to diagnosis. The first will be the geography where they occur, and the second will be the pathology. So we'll talk about both of those features now. So histoplasmosis and blastomycosis basically have the same geography. They both occur in the Ohio and Mississippi River valleys. Blastomycosis can occur a little bit around the Great Lakes, but basically these two are going to have the same geographical location of where they occur. Coccidiomycosis, on the other hand, occurs in the southwestern US. It is a disease that's very common in Mexico, so it occurs in the states that are near Mexico. And then paracoccidiomycosis is easy to remember because that doesn't occur in the United States. It occurs in South and Central America. So if you're not good at geography, you may need a reminder of where the Mississippi and Ohio river valleys are. So let's review that now. This is a map of the United States. So the Mississippi River starts up in Minnesota and it runs right down the middle of the United States all the way down to the Gulf of Mexico. The Ohio River starts in western Pennsylvania and then runs down below Ohio and intersects with the Mississippi River. So people who are at risk for histoplasmosis and blastomycosis are going to be in this area of the United States. Usually they will use the term Ohio or Mississippi River Valley, but sometimes they won't, and they will describe the Midwest, or you may hear the word Ohio or Mississippi in the question stem. Coccidiomycosis is a disease from Mexico. So if you can just remember that, it's easy to know the states where you're going to find it in the US. It's going to be in California and Arizona and New Mexico and all the states that are down here close to Mexico. So in question stems for histoplasmosis or blastomycosis, you'll often see the words Ohio River Valley, Mississippi River or River Valley, the Midwest, or sometimes the Great Lakes, especially for blastomycosis. For coccidiomycosis, they're usually going to name one of these three states, Arizona, New Mexico, or California. And then, as I said before, paracoccidiomycosis doesn't occur in the US. It occurs in South and Central America. So now let's talk about each of the fungal pneumonias individually. So the first one is histoplasmosis, which is caused by the fungi Histoplasmosis capsulatum. And in nature, this fungi is found in soil contaminated with bird or bat droppings. So a key site for infection is caves. And if you ever see a question stem that says a patient was spelunking in caves, this is one of the first things you should think about because they're often exposed to bat droppings when they do that. Humans inhale spores and then it becomes a yeast at body temperature. And once it gets inside the body, it's ingested by macrophages. And you can remember that tuberculosis is also ingested by macrophages. So histoplasmosis is similar size, it's taken up by the same cells. And so it makes sense that it also causes granulomatous inflammation, just like tuberculosis. Once this fungi gets inside macrophages, it can survive and multiply and then eventually spread to other macrophages in the lungs. The vast majority of people who are exposed to histoplasmosis are asymptomatic, and this is true for all the fungal pneumonias. If they ever ask you the most likely outcome of exposure, it's nothing. Most people don't ever get symptoms. When people do get symptoms from histoplasmosis, it's usually pulmonary. So they get a slow onset pneumonia over a few weeks. It's usually a mild pneumonia. They may have hilar lymphadenopathy on their chest x-ray. And again, just remember that this is a tuberculosis mimic, and you know that tuberculosis causes hilar lymphadenopathy. So it makes sense that they don't ever get symptoms. When people do get symptoms from histoplasmosis, it's usually pulmonary. So they get a slow onset pneumonia over a few weeks. It's usually a mild pneumonia. They may have hilar lymphadenopathy on their chest x-ray. And again, just remember that this is a tuberculosis mimic, and you know that tuberculosis causes hilar lymphadenopathy. So it makes sense that this does as well. You can diagnose histoplasmosis by blood tests for antigens and antibodies, but you can also do it by a biopsy. And on your USMLE Step 1 exam, they'll often show you a biopsy slide because it has some characteristic findings, which we'll see in a minute. And as I said before, this is treated the way all the fungal pneumonias are treated: fluconazole and itraconazole for mild disease, and severe or systemic disease treated with amphotericin B. And here are two pictures of macrophages filled with the yeast cells of histoplasmosis. And remember, this is a very small fungi, so many of them can fit inside one white blood cell like you see here. The cell-mediated immune system is very important for clearing this fungal infection, and that's another analogy to tuberculosis. The cell-mediated immune system is important in tuberculosis as well. This fungi can disseminate, but that's very rare unless people are immunocompromised. So people with HIV/AIDS or people who are on TNF-alpha inhibitor drugs, these are the type of people who rarely can get disseminated histoplasmosis. There are lots of symptoms of dissemination that you can read about. It can involve almost any symptom, including the GI tract, the central nervous system, the bone marrow, and the lymph nodes. Some key features that I think are worth knowing about so you can recognize this in question stems. The liver and the spleen will often be enlarged. Patients may have abnormal LFTs. Ulcers are a very unusual and easy to recognize symptom of disseminated histoplasmosis. These can occur in the tongue or in the mouth. And then you know that this fungi likes to infect macrophages, so it makes sense that it can infect other cells and therefore involve the bone marrow and cause pancytopenia. And the treatment for systemic disease is amphotericin B. The next fungal pneumonia is caused by Blastomyces dermatitidis. That's the causative agent of blastomycosis. So it shares many similarities with histoplasmosis. Just like with histo, you inhale the spores or conidia, and then they become a yeast inside the body. It's a dimorphic fungus. Just like with histo, most patients are asymptomatic, but when symptoms do develop, a slow onset pneumonia is the most common presentation. So there are many similarities between histoplasmosis and blastomycosis. They both have a similar geographic distribution, and they both cause a slow onset pneumonia. But one thing that's different about blastomycosis is that extrapulmonary disease is very common. About 20% of patients will have this. The skin is the most common site, so patients with blastomycosis can get these wart-type lesions with irregular borders on their skin. Then the second most common site is to have bone involvement and osteomyelitis from this infection. So the classic case of blastomycosis will be somebody with a Mississippi River exposure and slow onset pneumonia, and this can look a lot like histoplasmosis, but the unique features will be the presence of skin lesions and possibly bone pain. And then one other thing to remember is that histoplasmosis is associated with cave and bat exposure. That's not the case for blastomycosis. So blastomycosis forms granulomas, just like all these fungal pneumonias can. And the classic pathology finding is a broad-based budding yeast. And this is a picture of one down here. Most yeast cell mycosis forms granulomas, just like all these fungal pneumonias can. And the classic pathology finding is a broad-based budding yeast. And this is a picture of one down here. Most yeast cells, when they divide, will form a little stalk and then they will bud off a second yeast cell. This is called narrow-based budding, and this is very common. What blastomyces does that's unusual is that the second yeast cell that buds off will have a broad connection to the first one. So there's much more of the two cells touching each other. That's called a broad-based budding, and that's what's unique to blastomyces. And you can see that these cells are budding off with a broad connection to one another, and that's what's unique about blastomyces. And the diagnosis is usually by visualizing the yeast, either in sputum or in tissue, and it's treated like all the fungal pneumonias with fluconazole and itraconazole for mild disease and amphotericin B for severe or systemic disease. Next, let's talk about coccidiomycosis. So remember, it's common in Mexico. So you're going to find it in all the states that are near Mexico, like Arizona, New Mexico, Texas, and California. It grows as a mold beneath the desert surface, and in dry conditions, the mold fractures into spores. And you get sick from inhaling the spores, just like you get sick in all the fungal pneumonias from inhaling spores. What's unique about coccidiomycosis is that it's not dimorphic. In the lungs, the spore does not become a yeast. Instead, it enlarges to a structure called a spherule. This is not a yeast, so it's not dimorphic. The enlarging spherules produced in the lungs, the spore does not become a yeast. Instead, it enlarges to a structure called a spherule. This is not a yeast, so it's not dimorphic. The enlarging spherules produce endospores, and then the mature spherule rupture, and they release all their endospores, and each endospore can produce another spherule. So this is how it multiplies inside the body. So the classic pathology finding here is a spherule filled with endospores, and this is a picture of one. You can find lots of other ones online, but it's a structure that contains lots of smaller circular structures, and those are the endospores. Just like with all the fungal pneumonias, most infections are asymptomatic, but people who get sick get a condition called valley fever. So they have fever, malaise, and cough. They also get joint pains, and then they get a skin finding called erythema nodosum. Erythema nodosum is inflammation of the fat tissue under the shins. This is a picture of it over here. You can get this in a number of conditions. It's not specific for coccidiomycosis, but it does occur as part of valley fever. You can make the diagnosis by sputum culture. It very rarely disseminates, but when it does disseminate, the feared result is meningitis. There are reports of coccidiomeningitis, and people can get very sick. And the treatment is the same as for all the fungal pneumonias: fluconazole and itraconazole for mild disease, and amphotericin B for severe. ear disease. And the last of these fungal pneumonias is paracoccidiomycosis. So this doesn't happen often in the United States. It occurs in Central and South America. This means for a board question, they may very well describe to you someone who's recently traveled to one of these two places. Patients get pulmonary symptoms like a cough. And what's unique about this fungal infection that you need to know is that it has a classic pathfinding called the pilot's wheel or the Mickey Mouse head. So let's look down here on the right. What's happening down here is that you have a mother cell in the middle budding off multiple small cells on the side, and that's why it forms this structure that looks like a pilot's wheel. Sometimes it's described as a Mickey Mouse head. So if you look at this picture on the left, if you look up here, you've got a mother cell budding off two little daughter yeasts, and they almost look like Mickey Mouse ears. So if you hear a description of the pilot's wheel or the Mickey Mouse head, what they're describing is paracoccidiomycosis. And the reason is because the mother yeast cells bud off lots of little daughters all at the same time. Let me finish this module by mentioning Aspergillus. So I talk about Aspergillus in detail in the module on opportunistic fungal infections. But I mention it here because it can also cause pneumonia, but you should never ever confuse it with any of the fungal pneumonias mentioned in this module. So Aspergillus pneumonia only happens to people who are immunocompromised. So it's going to happen to people who have HIV or who are on chemotherapy. It has no specific geographic area. It can happen anywhere. Aspergillus is monomorphic. It does not form a yeast cell. So it's going to have hyphae, and you should never confuse it with any of the small yeast cells that we talked about in this module. And furthermore, patients who get Aspergillus pneumonia get very, very sick. So you should never, ever confuse it with any of the fungal pneumonias mentioned in this module. So Aspergillus pneumonia only happens to people who are immunocompromised. So it's going to happen to people who have HIV or who are on chemotherapy. It has no specific geographic area. It can happen anywhere. Aspergillus is monomorphic. It does not form a yeast cell. So it's going to have hyphae, and you should never confuse it with any of the small yeast cells that we talked about in this module. And furthermore, patients who get Aspergillus pneumonia get very, very sick. So they have fever, they get hemoptysis, pleuritic chest pain. It's going to look very different from the patients with mild pneumonia symptoms that we described in this module here. And that concludes our module on fungal pneumonias. Hello, everybody, and welcome to our module on fungal skin infections. So by way of review, there are three general categories of fungal infections. The first are the pneumonias, which I talk about in a separate module. We will talk about the skin fungal infections in this module. And then finally, there are opportunistic fungal infections that occur in people who are immunocompromised or otherwise vulnerable to one of these fungi. So some of the most common fungi that cause skin and nail infections are the dermatophytes. The dermatophyte is a group of fungi that all subsist on keratin, and they cause many types of fungal. So some of the most common fungi that cause skin and nail infections are the dermatophytes. The dermatophyte is a group of fungi that all subsist on keratin, and they cause many types of fungal infections, including tinea pedis, which you may know as athlete's foot, tinea cruris, which you may know as jock itch, tinea corporis, which you may know as ringworm, tinea capitis is a scalp infection, and tinea unguium is a nail infection. When you see the word tinea, it generally means a fungal infection of the skin or nails. Most of them are caused by dermatophytes, but not all. We'll talk about tinea versicolor in this module, which is not caused by a dermatophyte. And then finally, in this module, we'll talk about sporothrix, which is a unique sort of fungal skin infection. So let me just review a little terminology before we go on. So as I mentioned before, tinea means a fungal skin or nail infection, and dermatophytes are a group of fungi that require keratin for growth. And most tinea infections are caused by dermatophytes, but not all. And some people mix these two up and think that a tinea infection means a dermatophyte infection. That is correct all. We'll talk about tinea versicolor in this module, which is not caused by a dermatophyte. And then finally, in this module, we'll talk about sporothrix, which is a unique sort of fungal skin infection. So let me just review a little terminology before we go on. So as I mentioned before, tinea means a fungal skin or nail infection, and dermatophytes are a group of fungi that require keratin for growth. And most tinea infections are caused by dermatophytes, but not all. And some people mix these two up and think that a tinea infection means a dermatophyte infection. That is not necessarily true. We'll talk about tinea versicolor in this module, which causes a skin infection. It is a fungus, it's a tinea infection, but it is not caused by a dermatophyte. So the dermatophytes are a collection of fungi, and the majority of infections come from three dermatophytes. The first one is called Epidermophyton, and a tinea infection means a dermatophyte infection. That is not necessarily true. We'll talk about tinea versicolor in this module, which causes a skin infection. It is a fungus, it's a tinea infection, but it is not caused by a dermatophyte. So the dermatophytes are a collection of fungi, and the majority of infections come from three dermatophytes. The first one is called Epidermophyton, and it's got the word epidermis in it to remind you it causes skin problems. The second one is Trichophyton, and the third one is Microsporum. All of them consume keratin, as I said before. That's what makes them dermatophytes. A very important thing to remember, this can be helpful on board exams, is that these exist only as molds with hyphae. So you're never going to see budding yeast or anything like that on a biopsy or a specimen of these. You're always going to see hyphae. One is Trichophyton, and the third one is Microsporum. All of them consume keratin, as I said before. That's what makes them dermatophytes. A very important thing to remember, this can be helpful on board exams, is that these exist only as molds with hyphae. So you're never going to see budding yeast or anything like that on a biopsy or a specimen of these. You're always going to see hyphae. Most of them are treated with topical antifungals like cotrimazole and miconazole. These are members of the azole family of drugs. Some of them are treated with another drug called terbinafine. And one thing to note here, just so you don't get confused, is that nystatin is not effective against the dermatophytes. Nystatin is used for cutaneous candida, which is a diaper rash that occurs in babies. And I talk about this in the module on opportunistic fungi. But just remember that you would never use nystatin for one of these dermatophyte skin or nail infections. So many times these infections are diagnosed clinically. You just identify it on site. But if you want to do a test to confirm that a fungus is the cause of the infection, the test of choice is usually the KOH prep. So to do this, you take a scraping of one of the fungal infections, either the skin or the nail, and you add potassium hydroxide. The potassium hydroxide dissolves the epidermal keratinocytes, and then you can see the fungi under the microscope. What you will see is the hyphae. And this is used to diagnose not just the dermatophyte infections. You can also use it for tinea versicolor in Candida. We'll talk about the findings of tinea versicolor in a little bit. But for all of these fungi infections, the KOH prep is a useful test. So let's go through the dermatophyte infections one at a time. The first one is tinea unguium, which is also called onychomycosis. It's a fungal infection of the nails. Usually it's the toenails. This is a picture of it down here. It's mostly a cosmetic problem for obvious reasons. People don't like their toenails. Nails looking like this. And it's very difficult to treat topically, so usually oral treatment is used either with terbinafine or itraconazole. You have to take the medication for several months to clear the infection. Tinea pedis, you may know by its other name, which is athlete's foot. This is a fungal foot infection, and it likes to infect feet in a warm, moist environment. So that includes sweaty feet and feet in locker rooms, especially if they have little abrasions on them. The result of the infection is itchy red erosions, classically between the toes and on the soles. And if you don't treat it, you can get scaling on your feet. You can Google this online and see some pictures of nasty feet with scaling from tinea pedis infections. And this is usually treated topically. So topical antifungals like clotrimazole and miconazole. You can also use terbinafine. Next dermatophyte infection is tinea corporis, which is also called ringworm because it classically forms a ring on the skin, just like this picture down here. It's a skin fungal infection. It's itchy. It's usually circular or oval. It's got red, especially at the edges, and it's usually described as a scaling patch or plaque. It spreads centrifugally, so it starts in the middle here and moves out like in this picture. The border is usually red, but there's clearing in the center, and that's what makes it look like a ring, so that's why it's called ringworm. And this can be treated topically with antifungals like clotrimazole and miconazole and also terbinafine. Tinea capitis is a dermatophyte infection of the scalp. It usually occurs in children, and the classic demographic is African Americans. This is a picture of a child with tinea capitis, and you can see that there's this circular area that's got a little bit of a plaque on it. The plaque is hard to see, but more importantly, the hair is missing because of the fungal infection. It's described as a red scaling patch on the scalp. It spreads centrifugally, just like all the tinea infections. And this one is kind of like the nail infections. You usually have to use oral treatment. So griseofulvin, terbinafine, or itraconazole oral medications are usually used. Tinea cruris is also called jock itch. This is a fungal infection of the groin. It's more common in men. It's common after physical activity. When you sweat, that creates a favorable environment for the fungus, especially if you don't shower well. This is a picture of it down here, and you can see that this man has this red, well-demarcated plaque in the groin, and that's pretty classic for jock itch. Obesity increases the risk because when you're obese, you have deep skin folds here in the groin where the fungus can hide and thrive. It presents as a red patch on the inner thigh and spreads centrifugally, and the key is a red, sharply demarcated border, just like you can see in this picture over here. This can be treated topically with clotrimazole and miconazole and also terbinafine. The next fungal infection is called tinea versicolor, and all the infections named tinea we've discussed up till now have been dermatophyte infections. Tinea versicolor is the one exception. It is called tinea, but it's not caused by a dermatophyte. It also goes by the name pityriasis versicolor, and it's caused by species of fungi called Malassezia. These are dimorphic fungi. This is very different from the dermatophytes. Remember, the dermatophytes exist only as a form with hyphae present. These fungi can exist as yeast or a mycelial form. They're part of the normal skin flora, but sometimes the yeast on the skin can transform into the hyphae mycelial form, and this is what causes disease. And triggers for transformation include hot, humid weather, sweating, or topical skin oils. So as you can imagine, people that come back from a tropical vacation to the beach are at risk to develop tinea versicolor. What this fungi does is it degrades lipids and they turn into acids, and these acids can damage melanocytes, and the result is hypopigmented skin. This is a picture of tinea versicolor down here. And remember what I said before, it's not a dermatophyte because it does not consume keratin. Now, one thing to keep in mind, this is often someone who's just come back from a beach vacation. Remember that the warm, hot, humid sun is a trigger for this infection. So they will come back and be very suntanned, but they will complain that there is a spot on their skin that is not suntanned, and it will look something like this. And the reason it looks like this, the reason it's hypopigmented and not suntanned, is because they have a fungal infection of their skin. A high yield thing to know about this fungi for your boards, especially step one, is that the KOH prep will show hyphae and yeast cells. Remember that for the dermatophytes, you're never going to see yeast cells because they don't exist as yeast. And the presence of both hyphae and yeast is often described as spaghetti and meatballs. This is a picture down here, and this is another picture here. There are even better examples you can find in textbooks and online. But what you see are hyphae like this right here, and then you also see the little yeast forms, which are circles, and so that's described as spaghetti and meatballs. You treat it topically with azoles. There's also a topical medication called selenium sulfide. This promotes shedding of the stratum corneum, which you may recall is the uppermost layer of the epidermis. And when that sheds off, it will often rid the body of the fungus. The final fungal skin infection we'll discuss is that caused by Sporothrix schenki or Schenka, and this is the causative agent of sporotrichosis. So Sporothrix is a dimorphic yeast that lives on plants. And what happens is you get spores introduced into your skins with little trauma. That's why it's called rose gardener's disease, because rose gardeners will get irritated hands from working in the garden, and then the spores will get into their skin. What happens is a few days or even weeks later, they'll get a papule at the site of trauma. And then the fungi travels up the arms via the lymphatic channels. This is a process called ascending lymphangitis. As a result, they will end up with similar lesions all along the lymph channels going up their arm from the hand up to their shoulders. So the classic picture to show you on their boards, and you can find examples of this online, is someone who's got a papule down near their hand, and then they've got little papules going all the way up their arm to the shoulder. This is often diagnosed clinically just by recognition of the classic rash, but you can also diagnose it with a fungal culture. And there are two possible treatments. The first is to use oral itraconazole, and the second is to use a very unusual treatment called saturated solution of potassium iodide, or SSKI. This is a very old therapy. It's over 100 years old. And what you do is you take drops of potassium iodide and you put it in juice or milk. And if you drink that for a few weeks, it will clear the infection. The mechanism is not clearly understood. A lot of people can't tolerate it because of nausea and other side effects. So a lot of people use itraconazole to treat this, but SSKI is still an accepted therapy for sporotrichosis. And that concludes our module on fungal skin infection. Hi, everyone, and welcome to our module on opportunistic fungal infections. So you can break fungal infections down into three general categories. There are the fungal pneumonias, there are the fungal skin infections, and then finally there are the opportunistic fungi infections. And that's what we'll talk about in this module. And these fungi include Candida, Aspergillus, Cryptococcus and Mucormycosis, and finally Pneumocystis. Candida is part of the normal flora of human beings. You can find it in the mouth and intestine, you can find it in the skin and the vagina. And one thing that's high yield for step one and also very clinically relevant for your third year rotations is that Candida is a common contaminant of sputum culture. So there is no such thing as Candida pneumonia. And if you send a sputum culture in a patient with pneumonia to the lab and it comes back positive for Candida, that is not the cause of the lung infection. That is a contaminant and it's normal flora of the mouth and the esophagus. The way Candida makes people sick is that it overgrows when it shouldn't. So if it overgrows in the mouth, you can get oral thrush. If you get Candida overgrowth in the esophagus, you can get esophagitis. There's normally some Candida in the esophagus, but if you get too much, it'll give you esophagitis. When you get Candida overgrowth in the vagina, especially in women who've been on antibiotics, that's called vulvovaginitis, or many women just call it a yeast infection. And then sometimes babies get a diaper rash, which can be caused by Candida. Candida can also disseminate, especially if you are sick, is that it overgrows when it shouldn't. So if it overgrows in the mouth, you can get oral thrush. If you get Candida overgrowth in the esophagus, you can get esophagitis. There's normally some Candida in the esophagus, but if you get too much, it'll give you esophagitis. When you get Candida overgrowth in the vagina, especially in women who've been on antibiotics, that's called vulvovaginitis, or many women just call it a yeast infection. And then sometimes babies get a diaper rash, which can be caused by Candida. Candida can also disseminate, especially if you are severely ill or immunocompromised. And when Candida disseminates and gets into the bloodstream, it can be a rare cause of endocarditis, and it can disseminate to almost any organ. This is called candidemia when it gets into the bloodstream, and disseminated candidiasis can affect almost anywhere potentially. Candida is a dimorphic fungus, so it can exist as a single-celled yeast or as a mycelium with hyphae. But really what you need to remember about Candida is that it likes to form two unique shapes, and these are very high yield for you to remember for your boards. The first unique shape that Candida likes to form is that of the pseudohyphae. These are elongated budding yeast cells, and it's easiest to understand this with a picture. So imagine that you have a circular yeast cell and it buds off another circular yeast cell, but imagine that they stay attached and then begin to elongate. Well, you could get two elongated yeast cells like this with a constriction between them, but it's not really a septate, it's just a constriction. And that is a pseudohyphae. It looks like a long branch. It looks sort of like a hyphae, but it is not a hyphae. It's not two separate cells with a septa between them. It is two yeast cells that are stretched out with a narrowing between them. That's what a pseudohyphae is. In addition to pseudohyphae, Candida likes to form germ tubes, and this is the basis of a test for Candida called the germ tube test. So what you do is if you have a lesion that's suspicious for Candida, you take a little bit of a scraping of it and you put it in a tube and you heat it and incubate it at about 35 degrees for a few hours. And if it's Candida, what will happen is that the yeast will sprout hyphae. Those are called germ tubes, and that's what it looks like down here in this picture. These are germ tubes. So these are the yeast cells here, and these hyphae are sprouting out of them. And when you see these germ tubes start to form after you take it out of the incubator, you know you're dealing with Candida, and that's how you can test for it in the laboratory. So this is a zoomed in picture of what I showed on the last slide to demonstrate pseudohyphae. And what you can see here is in the top right corner, you've got circular yeast cells. And then in the middle and the bottom of the slide, you've got these long branches here. And usually you will not see yeast cells and branching hyphae together on one side. If you think about all the specimen slides we've looked at for the fungal pneumonias and ones we'll look at later for Aspergillus and other is two yeast cells that are stretched out with a narrowing between them. That's what a pseudohyphae is. In addition to pseudohyphae, Candida likes to form germ tubes, and this is the basis of a test for Candida called the germ tube test. So what you do is if you have a lesion that's suspicious for Candida, you take a little bit of a scraping of it and you put it in a tube and you heat it and incubate it at about 35 degrees for a few hours. And if it's Candida, what will happen is that the yeast will sprout hyphae. Those are called germ tubes, and that's what it looks like down here in this picture. These are germ tubes. So these are the yeast cells here, and these hyphae are sprouting out of them. And when you see these germ tubes start to form after you take it out of the incubator, you know you're dealing with Candida, and that's how you can test for it in the laboratory. So this is a zoomed in picture of what I showed on the last slide to demonstrate pseudohyphae. And what you can see here is in the top right corner, you've got circular yeast cells. And then in the middle and the bottom of the slide, you've got these long branches here. And usually you will not see yeast cells and branching hyphae together on one side. If you think about all the specimen slides we've looked at for the fungal pneumonias and ones we'll look at later for Aspergillus and other, generally you see hyphae or yeast, but not both. When you see both present in one slide, then you're most likely looking at Candida because you're not really seeing hyphae, you're actually seeing pseudohyphae, which are budding yeast. Very unusual for hyphae and yeast cells to exist at the same time in the same environment. As I mentioned before, Candida Can cause a number of overgrowth diseases. So let's talk about these in a little more detail. The first one is oral thrush. This is a picture of it right here. It's a white plaque that grows on the tongue or the buccal mucosa or the back of the pharynx, and it's caused because the candida, which is normally present there, has begun to overgrow. The classic patient to develop this is an asthma patient who's taking inhaled steroids and not using the steroid inhaler properly, and it's getting on their tongue and their mouth, and they're becoming relatively immunocompromised, and thus the candida can overgrow. Thrush is also a common presentation for patients with HIV. They don't know they have HIV, and then they present to their doctor with thrush. So if you see a board question and the question stem states the patient is sexually active and now has thrush, you should think of HIV. Patients who have HIV and AIDS can get candida overgrowth in their esophagus, and this is called esophagitis. They will have a white pseudomembrane when you take a look in their esophagus with a scope. That's called an EGD. Women get what's called a yeast infection. This is vulvovaginitis caused by candida overgrowth in the vagina. These women will have itching and discharge, and the discharge is classically described as cottage cheese in appearance. And the classic woman to get this is someone who has taken an antibiotics. This decreases the normal flora in the vagina and allows the candida to overgrow. And then finally, babies will sometimes get a diaper rash. There are many causes of diaper rash, including just irritation of the skin. But one cause is Candida, the fungal infection, and these babies will have beefy red plaques with satellite papules in the region covered by their diaper. Candida is a very rare cause of endocarditis. This is almost always in an IV drug user who gets the Candida into their bloodstream. And then finally, patients who get candidemia, which is Candida in the bloodstream for any reason, including IV drug use, can have disseminated candidiasis, which can spread to any organ system. So let's talk about which patients are at risk for candidemia. Candidemia happens to patients who are immunosuppressed. Candidemia is a major problem in patients who are neutropenic from chemo, especially patients in the hospital getting bone marrow transplants. They receive very high dose chemo and become severely immunocompromised. Patients who are critically ill in the ICU can get candidemia. This is very common. Patients who have central lines are at increased risk. The central line can be a source of the candida in the bloodstream. Any patient receiving IV nutrition, which is called total parenteral nutrition or hyperalimentation, is at increased risk. The nutrients that are delivered directly into the venous system increase the risk of candida and allow candida to thrive. And then finally, as I mentioned before, IV drug users are at risk for candidemia and can get candida endocarditis. The treatment of candidiasis depends on where the infection occurs. Women who have vulval vaginitis or babies with diaper rash can be treated with a topical azole. A single dose of fluconazole is sometimes given to treat yeast infection in women. Oral thrush is classically treated with the nystatin swish and swallow. Nystatin is an antifungal drug that works just like amphotericin B, but it's toxic if given systemically. So its main use is topical or the swish and swallow for thrush. You can also use fluconazole to treat thrush. People with esophagitis are treated with fluconazole, and there are resistant cases where more aggressive antifungal agents are used, like voriconazole and caspofungin. And then finally, candidemia and endocarditis is usually treated with a potent antifungal agent like caspofungin or amphotericin B. You can sometimes use fluconazole if the patient's stable and not immunocompromised. There's a rare genetic mutation called chronic mucocutaneous candidiasis. This is a genetic mutation in autoimmune regulator genes called AIR genes. As a result of these mutations, these babies are born with T cell dysfunction and they can't react to candida antigens normally. As a result, they get chronic skin, mucous membrane, and candidal infections. So the way this will present in a board question is a child who has recurrent thrush and diaper rash, and they're probably going to ask you something about either the AIR genes or the T cells, which are dysfunctional. You should be aware that different cells of the immune system play different roles in defending us against candida infections. T cells, it turns out, are very important for mucosal defense. As evidence of this, HIV patients often get oral thrush when they have low CD4 counts. On the other hand, neutrophils are the most important cells for systemic defense. And as evidence of this, HIV patients rarely get candidemia because their neutrophils are intact. In addition, you rarely see candidemia and chronic mucocutaneous candidiasis. On the other hand, chemo patients often get candidemia. They are neutropenic and they are at great risk for candida bloodstream infections. And candidemia is a major problem on bone marrow transplant units. And I've put a nice review article down here at the bottom of the screen if you want to read more about all the evidence of how T cells play an important role against mucosal defense against candida. Next, let's talk about Aspergillus. So Aspergillus is a fungus that's found everywhere in nature. It's ubiquitous. There are a number of different subspecies that cause infection. There's Fumigatus, Flavus, and Terreus. And generally, the way you get sick from Aspergillus is by inhaling the spores or the conidia. And in order to get sick from Aspergillus in general, you need to have some type of immunocompromise. It generally does not cause disease in people who are healthy and well. And a classic patient to get sick from Aspergillus, especially in the hospital, one that you're likely to see on rotations, are patients receiving high-dose chemotherapy, especially for stem cell transplants. Aspergillus is a major pathogen that causes morbidity and lots of mortality among patients who undergo stem cell transplants. Couple of features of Aspergillus that it's high yield to remember. First of all, it is a fungi that has the catalase enzyme that is catalase positive. This means it's a common pathogen in chronic granulomatous disease. This is a rare condition where people are at great risk for infection from catalase positive organisms. It's a monomorphic fungi. It does not form yeast cells. So if you ever see a biopsy slide in a board question with small circular yeast, you are not looking at Aspergillus. It forms branching septated hyphae. So it likes to form hyphae at branches that look like V's. We'll see some picture in a minute. But I always remember that the A in high yield to remember. First of all, it is a fungi that has the catalase enzyme that is catalase positive. This means it's a common pathogen in chronic granulomatous disease. This is a rare condition where people are at great risk for infection from catalase positive organisms. It's a monomorphic fungi. It does not form yeast cells. So if you ever see a biopsy slide in a board question with small circular yeast, you are not looking at Aspergillus. It forms branching septated hyphae. So it likes to form hyphae at branches that look like V's. We'll see some picture in a minute. But I always remember that the A in Aspergillus is like an upside down V, and that reminds me that it forms these V-shaped branches. And you can usually see septa in the hyphae. So especially on board questions, they're most likely going to show you hyphae where you can visibly see the divisions made by the septae. And then finally, the tips of some hyphae grow spores. These are called conidiophores, and this is how the spores get in nature, and they later get inhaled and cause disease. So here's a picture of an Aspergillus hyphae with a conidiophore on the end, and these little dots are little spores that it's going to release. Down here in the bottom right is a picture of some of the hyphae, and you can see that the branches always look like V's. All the branches look like V's. If you see lots of irregular branching and they don't all look like V's, then you're looking at some other fungus, probably mucormycosis. And then up here in the top right, I've zoomed in just so you can see that there are septae right here that you can visualize easily. And in pictures of Aspergillus and board questions, you're almost certainly going to be able to see those septated hyphae. Aspergillus causes 4 diseases that you need to know about. The first one is aspergillosis, and this is the classic severe pneumonia that happens to patients who are neutropenic. We'll talk more about that in a minute. Aspergillus can also cause a condition called allergic bronchopulmonary aspergillosis. This is an allergic reaction to the fungi that happens in patients who have cystic fibrosis or asthma. Aspergillus can invade preformed lung cavities, classically cavities created by tuberculosis, and form a fungus ball. This is called an aspergilloma. And then finally, Aspergillus makes a toxin that's strongly associated with hepatocellular carcinoma. It's called an aflatoxin. We'll talk about that in a minute. Allergic bronchopulmonary aspergillosis, or ABPA, is a hypersensitivity reaction to Aspergillus. What happens in patients with this condition is the lungs become colonized with aspergillus, an aflatoxin. We'll talk about that in a minute. Allergic bronchopulmonary aspergillosis, or ABPA, is a hypersensitivity reaction to Aspergillus. What happens in patients with this condition is the lungs become colonized with Aspergillus, and this occurs primarily in people who have some type of defect in their lung function. So it typically happens to people who have asthma or cystic fibrosis. And there are some classic findings of ABPA that are high yield to know for your board. So when they look at the lymph tissue in patients who have ABPA, they find increased numbers of Th2 CD4 cells. And these cells synthesize interleukins like IL-4 and IL-5. And you should know that IL-4 and IL-5 are 2 of the interleukins classically created by Th2 cells, and they are synthesized in this condition of ABPA. These interleukins then stimulate eosinophilia, and they stimulate the production of IgE. Antibodies, and these 2 are classic findings in patients who have ABPA. So make sure you know the immunology of this, because it's a nice tie-in between microbiology and immunology that board examiners like to ask you about. So the classic case is a patient who has either asthma or cystic fibrosis and has recurrent episodes of cough, fever, and malaise. During these episodes, there may also be mucus plugs and hemoptysis. The peripheral blood examination is going to show eosinophilia, and there are going to be high levels of IgE detected. You can diagnose this by skin testing for aspergillosis, and you can treat it with steroids. And especially on step 1, they're most likely going to describe a case like this and then ask you something about the Th2 CD4 cells and the interleukins that they secrete. The next Aspergillus disease is an aspergilloma, which is a fungus ball caused by Aspergillus fumigatus. Aspergillus fumigatus likes to grow in preformed cavities. Pulmonary tuberculosis is the most common association. So often this is someone who previously had tuberculosis and it left behind a cavity in the upper lobe, and the aspergillus gets inside and begins to grow. These fungus balls are actually often asymptomatic and detected on routine imaging or imaging of the chest done for another reason, but sometimes they can cause hemoptysis. You diagnose it often just by imaging in the classic patient, or you do a sputum culture. And sometimes these are just just observed if they're asymptomatic, but if you do want to remove the fungus ball, it'll require surgery. There's a toxin produced by Aspergillus that's associated with hepatocellular carcinoma. It's called aflatoxin, and this toxin can contaminate corn and soybean and peanuts. Remember that Aspergillus is found ubiquitously in nature, so it can produce this toxin. It can get into these types of foods, and if you eat a lot of foods that are contaminated with aflatoxin, you can get hepatocellular carcinoma. Now, industrialized countries like the United States screen for aflatoxin, and they don't allow foods to be sold that contain the toxin. But patients can get exposed if they eat lots of food from non-industrialized countries, or maybe they emigrated from a non-industrialized country where this toxin got into the food, or people that eat lots of locally grown foods that may be contaminated and aren't screened. The next fungi is Cryptococcus neoformans, and this fungi exists only as a yeast. It's like the opposite of aspergillosis. You are never going to see hyphae coming from Cryptococcus. And one thing that's high yield to know about it is that it has a very thick capsule, which is relatively unique among fungi. Its main disease it causes is meningitis, and this is only going to occur in people who have HIV/AIDS or people who are immunocompromised from chemotherapy or post-organ transplant. Cryptococcus is found in the soil, and it's also found in pigeon droppings, and people inhale the yeast, which then goes to the lungs and the bloodstream and gets to the meninges. It can very rarely cause pneumonia. There are reports of cryptococcal pneumonia, and it can rarely spread to other tissues. But as I said before, the most important disease to know about is meningitis. Couple of high yield items to know about Cryptococcus. The first is that it can be cultured on Sabaros agar, and Sabaros agar is a growth medium used for yeast and fungi, and the classic pathogen to grow on it is Cryptococcus. Another thing to know is that India ink staining of Cryptococcus samples will show capsules with halos. So this is an example of that down here. So India ink is a negative stain. It makes the background dark so that the yeast stand out. You can see that all these little circles have these halos around them, and those halos are caused by the capsule present in Cryptococcus. Another thing to know is that there is a test for Cryptococcus called a latex agglutination test. So in this test, you mix a sample with latex beads that are coated with an antibody to detect capsular antigen. So if the capsular antigen is present, meaning if the sample contains Cryptococcus, the latex beads will clump together. That's called agglutination. So when you mix a sample with these latex beads, if they clump together, it means there is presence of the Cryptococcus capsular antigen. And this is another way of detecting the presence of that capsule. Remember, the capsule in Cryptococcus is very high yield to know about. It's something they like to ask you about on step 1. Patients with cryptococcal meningitis have indolent symptoms that develop over weeks, symptoms like fever and headache. And this is very different from bacterial meningitis, which has acute symptoms that develop rapidly over a few days. Cryptococcal meningitis classically raises the pressure inside the brain and the skull. The ICP can get very high. And in fact, there is a risk of herniation when you do a lumbar puncture or a spinal tap. So you must do some type of imaging before you do the spinal tap to see if there's evidence of hydrocephalus and increased ICP. The treatment for cryptococcal meningitis is either amphotericin B, and you sometimes add flucytosine to it. The main use of flucytosine is by adding it to Ampho B for treatment of cryptococcal meningitis. You can also use fluconazole, and sometimes intrathecal therapy is used, and they like you to know about this for step 1. Sometimes you need to directly administer the antifungal agents into the cerebral spinal fluid in the spinal canal. Next, let's talk about the condition mucormycosis. This is a very rare fungal infection of the nose, eyes, and brain, and it's caused by 2 types of fungi. The first one is called mucor, and that's easy to remember because it's in the name of the disease. The other one is called rhizopus. And both of these fungi have an important enzyme called ketone reductase. And so, as you can imagine, this means they thrive in environments where there's high glucose and ketoacidosis present. So the serum from patients with DKA has actually been shown to stimulate growth of these fungi. So you can imagine that risk factors for mucormycosis include diabetes, especially diabetic ketoacidosis. It can also happen in other patients who are immunocompromised, like patients on steroids, patients with leukemia, and patients receiving stem cell transplants. But the classic condition to cause mucormycosis is diabetic ketoacidosis. You get disease when you inhale the spores and then it enters the nose and the alveoli. It is called an angio-invasive fungi, which means it invades the vessel walls. It classically starts at the sinuses and then spreads to adjacent structures. So Aspergillus likes to go to the lungs and cause pneumonia, but what mucormycosis infections do is they often start in the sinuses and involve the nose and the eyes and the brain more than the lungs. The sinuses and involve the nose and the eyes and the brain more than the lungs. Patients with mucormycosis get severe sinusitis, fever, discharge, congestion, sinus pain. If you ever see something like this happening in a patient with DKA, especially in a board question, you should think of mucormycosis. There can be necrosis of the palate. So when you look in the mouth, you can see dead, dying tissue. There can be redness and cyanosis of the skin over the face and sinuses, and this is because the fungi is eating away the blood supply. Black eschars may be seen. Eschars are black, dead, dying tissue. There's often pain and swelling around the eyes. The face can get numb from damage to the cranial nerves. And then finally, mucormycosis can trigger cavernous sinus thrombosis. I talk about this in the modules on neurology, but the cavernous sinus contains several important neurological structures. And if you get a thrombosis of that sinus, you can get multiple findings in the head and neck. So the classic case is a patient with DKA who's being treated for the acidosis and then develops fever, headache, and eye pain. You diagnose it by a biopsy, and we'll see some pictures of these fungi in a minute. And the treatment is to surgically debride the infected area and use amphotericin B. So the trick to mucormycosis is differentiating it from Aspergillus under the microscope, because both fungi can infect immunocompromised people and both have high There are a couple of important distinctions, though, to help you recognize mucormycosis. Mucormycosis shows very broad hyphae. So let's look at these hyphae. They're very wide, much different than the narrow hyphae you see in Aspergillus. In addition, the branching here is irregular. So in Aspergillus, you will see lots and lots of V's, lots of V-shaped branching. I wrote that on the screen for you here. In this picture down here, you see irregular branching. There are some that look like V's, but there are other that almost look like a T here. It's very irregular. And then finally, mucormycosis usually shows no septations or very rare septations. And in Aspergillus, they will always show you a biopsy sample with lots of septations. So just remember that Aspergillus has that narrow, regular V-shaped branching with many septations. Mucormycosis is different, broad hyphae, irregular branching, and usually no septation seen. The last fungal infection we'll discuss is Pneumocystis jirovecii, which causes pneumocystis pneumonia, which is usually just called PCP. It's a diffuse interstitial pneumonia that requires immunocompromise. It's a classic HIV illness. It's an AIDS-defining illness. It's one of the ways people first started to present with HIV in the 1980s when the virus became prevalent. It exists only as a yeast, which gets inhaled, and there's usually no symptoms if your immune system works. And the chest X-ray classically is markedly abnormal in PCP pneumonia. It shows diffuse bilateral interstitial infiltrates. Again, when HIV first came on the scene in the 1980s, healthy young homosexual men began presenting with severe pneumonias that showed a whiteout on their X-ray. And that's how I always remember what PCP pneumonia looks like. It's diagnosed by microscopy, and they like to show you these microscopy images on step one. You can do a sputum sample or a bronchoalveolar lavage or take a biopsy, and then you send it for special stains or antibody testing. One thing that's important to know is you can't culture PCP pneumonia, so you have to identify it through some type of stain. And special stains are used, and they're usually silver. So just remember silver stains for PCP. And these are some examples of them down here. And remember, it's a yeast, so you're not going to see any hyphae. You're going to see small circles. And they use silver stains, which usually make the yeast very dark. So you can see how there are dark little circles in the lungs in this picture on the bottom right. And this is a different stain here in the bottom left, but again, it's dark little circles present in the lungs. And if you see those, you're looking at Pneumocystis jirovecii and PCP pneumonia. The first line, those you're them down here. And remember, it's a yeast, so you're not going to see any hyphae. You're going to see small circles, and they use silver stains, which usually make the yeast very dark. So you can see how there are dark little circles in the lungs in this picture on the bottom right. And this is a different stain here in the bottom left, but again, it's dark little circles present in the lungs. And if you see those, you're looking at Pneumocystis jirovecii and PCP pneumonia. The first-line treatment for pneumocystis pneumonia is Bactrim, which is TMP-SMX. This is an inhibitor of the tetrahydrofolate synthesis pathway in the fungi. You can also use Dapsone, which is not a sulfonamide, but works just like sulfonamides to inhibit tetrahydrofolate synthesis. And then finally, there's a drug that's really only used in this situation, pentamidine. It can be used inhaled in addition to through other methods, and its mechanism is not entirely clear. It was developed to treat trypanosome infections in Africa, but it has efficacy against pneumocystis pneumonia as well. And this is probably the only time you'll ever be asked about pentamidine in a step one question will be for the treatment of pneumocystis jirovecii. Prophylaxis is done in patients with HIV/AIDS, so they often put people on Bactrim when their CD4 count gets below 200 cells per microliter, because this is when they become at risk for pneumocystis pneumonia. Many patients who take high-dose steroids or other immunosuppressant drugs are also placed on TMP-SMX, and this is also being done to decrease the risk of pneumocystis jirovecii infection. And that concludes our module on opportunistic fungal infections.
Mindful. Can I see? Oh shit. That's right. Yeah. Blastomycosis. Spheroid. Coccidiomycosis. Oh yeah. Meningitis. No. Itraconazole. Fluconazole. The long what form is what is a parasitic cause? Bacterias. Annual tongue on 6.90. Hard. Blastomycosis. Spherules. Fungal hyphae. At the ends of hyphae. At cold temperatures. Yeast at hot temperatures. Endospores. Is the clinical name given to dermaphyte infections? Tinea. What are the microbes that cause dermaphyte infections? Tinea pedis, Tinea capitis, Tinea corporis, Tinea urginus. Microscope. Tinea pedis. Tinea crurus. Tinea corporis. Keratin. Test is used to diagnose a dermatophyte infection. KOH. Tinea U. Unguium. For dermatophytes, that's a specific diagnostic tool. Microsporum. Oops. Malassezia furfur. Tinea versicollis. Spaghetti and meatballs. Degradation of lipids in skin into acids. Spaghetti and meatballs. Ketoconazole. Azoles. Ketoconazole. Selenium sulfate. Is diagnosed by which KOH lipids melan. Oh, okay. Saddam base. Sporotrichosis. Sporothrix. Rose gardeners. Right? Chenki. Sporothrix chenki. Rose gardeners disease. What is the treatment for this? Potassium iodide in orange juice or milk, or itraconazole, or trapezial lymphatics ascending lymphangitis. In the bushes, plants, is a dash-shaped budding yeast, cigar-shaped. Which dermatophyte? Microsporum. Epidermophyton trichoderma. Dermatophytes only exist as yeast or mold. They only exist as yeast. Exists as mold. Only exist as mold. Sporothrix chenki. Microsporum. Tinea captis. Athlete's foot. Oh. Interdigital vesicular voxel. Which type of dermatophyte infection associated with lymphadenopathy? Sporothrix chenki. Oh. Cat or dog. Okay. Tinea pedis. Tinea versicolor. Tinea versicolor. Also called as athlete's foot. Also called as jock itch. Good. Corpus. Toenail. Restore. Microspore. Oh yeah. 90 cards. Temporary form. Pseudo hyphae. Positive. Aspergillus. Conidiophores. Hypersensitive TH2. Asthma system. Aspergillomas caused due to Aspergillus fumigatus. Uh, Aspergilloma. Aflatoxin. Aflatoxin. HCC hepatocellular carcinoma. Allergic bronchoaspergillosis. TH2. Cause what conditions? Bronchitis is eosinophilia. Immunosuppression. Okay. Fumigatus. TB. Okay. Aflatoxin. Aspergillus is catalase. Positive. Cats, cat, Nocardia, Pseudomonas, Pseudomonas, Stadias. Sorry. I know Conidia, sorry. Candida and Aspergillus. Aspergillus. Conidiophore. Type 1. They cause a chronic mucocutaneous candidiasis. Really capsulated. Cryptococcus neoformans. Yes. Meningitis. Pigeon droppings. Soil. India ink. No, Saburot Zaga. India ink. Musicali. Polysaccharide capsular altitude. Latex agglutination test. Cryptococcus. Oh, it's urease positive. Mucormycosis. Again, immunocompromised patients. Oh, diabetic patients are mucormycosis, rhizopus, ketoacidotic, and neutropenic again. Which stain is needed to visualize pneumocystis zerovicii? Silver stain, yeah. What is first line treatment for pneumocystis zerovicii? Cotrimoxazole, yes. CD less than 200. What drug is used to treat pneumocystis zerovicii prophylaxis? Cotrimoxazole. Bactrim. Oh, dapsone. Canada. Vulvovaginitis from Canada is also known as yeast infection. It's due to mutation in autoimmune regulatory genes. Opportunistic fungal infection that grows. Aspergillus. Redexa, polysaccharide, and Cryptococcus. Uh, Silverstein. Canada. Because I neutropenic. Yo, germ tubules. Come on. Pseudohyphae. CD associated with esophagus is 100. Less than 100. Cryptococcus neoformans. Yeast. Which fungus? Cryptococcus neoformans. Which fungi causes mucormycosis? Pneumocystis. Mucormycosis. That's different. Penetrates the blood-brain barrier. Cribriform plate. What is treatment for mucormycosis? Study this. Pneumocystis zerovicii. Canada. Can get what? Canada infection in the CV. Oral thrush. Canada oral thrush is capable. T cells. Allergic bronchopulmonary aspergillosis. Alright, just a look. DASH deficiency can predispose patient to invasive aspergillosis or neutrophil. So oral thrush, acrovulvovaginitis. Canada aspergillosis. You got acute angle aspergillosis. They get the allergic bronchopulmonary aspergillosis. Which cytokines are important for pathogenesis of IL-4, IL-5? Oh, right, CD4, no, TH2. Okay. Cryptococcus neoformans. India in music. Music. Dash lesions can be seen in the brain imaging. So problem. What is the initial treatment for Cryptococcus neoformans? Cotrimoxazole. இல்லடா யூசஸ் 0H amphotericin B plus flucytosine. What's treatment for amphotericin B plus flucytosine followed by fluconazole maintenance therapy? Fluconazole maintenance therapy. Mucormycosis. Repeated. Oh, yeah, mucormycosis. Not hepatitis. Non-septate, wide branching, mucormycosis. Okay. Pneumocystis jirovecii causes pneumonia with a ground glass infiltrate. Which anti-malarial drug can be used to treat pneumocystis? Dapsone. No. Atowacone. Toe on my cone. Oh, we studied it today. Strength focus. In HIV patients, the CD4 cell count associated with vaginal vulvovaginitis. Sorry, Candida vulvovaginitis. Esophagitis. It's the same for both. Oral thrush when it below 500. Cricoid vulvovaginitis. Okay. That's cool, bro. I'm done with this shit, bro. ஹலோ ஹலோ சொல்லுங்க. ஆமா அசிங்கம் ப்ரோ, எவ்வளோ கேவலமா கொடுத்துருக்காங்க மற்ற டேர்லாம். அதே மாதிரி பண்ணி விடுங்க. எப்படியும் எவனும் பண்ண மாட்டான். ஆ என்ன சொல்ற மாதிரி ப்ரோ, ஒரு காமெடியா இருக்கணும் ப்ரோ, எல்லாமே லைட்டா எடுத்துக்கோங்க. எப்படி செலெக்ஷன் கரெக்டா? சரிப்பா, முடிஞ்சா பண்ணுங்க. மோஸ்டா எவனும் பண்ண மாட்டான். அதெல்லாம் ரொம்ப அசிங்கமா இருக்கு நிறைய இதெல்லாம். தெரியலையே, அது சீக்கிரட்டா சொல்ல மாட்டாங்க ப்ரோ. ஆனா எவனுமே அனுப்பல. ஏதாச்சும் பொண்ணா இருக்கும், பொண்ணா இருக்கும்னு நினைக்கிறேன். அதான் அனுப்பல. இல்ல ப்ரோ, கண்டிப்பா இருக்காது. ஆமா, அதான் ஏதோ பொண்ணா இருக்கும். அதான், அதுவும் எனக்கு தெரியாத பொண்ணா இருக்கும். போ, ரேப் பண்ணிட்டாங்க ப்ரோ. அதெல்லாம் நடக்காது ப்ரோ. ப்ரோ அட்லீஸ்ட் எனக்கு எவனுமே கிஃப்ட் வாங்கியிருக்க மாட்டாங்க ப்ரோ. அந்த பொண்ணா இருந்தா யாரு, அவ்வளவுதான், வேஸ்ட். நாளைக்கா தரணும்? ஆமா ப்ரோ, நான் அப்போ உங்களுக்கு நாளைக்கு வாங்கி தரேன். எதுவுமே வாங்கல ப்ரோ, இன்னைக்கு தானே பேரே வந்துச்சு. ஸோ நாளைக்கு ஏதாச்சும் ஃபெமினா போய் வாங்கி தரேன். அதான் சொன்னேன் ப்ரோ, நாளைக்கு போய் வாங்கலாம். சரி, படிச்சிங்களா? ரிவிஷன் மைக்காலஜி படிச்சிங்களா? ஒன்லியா? 2 எஸ்ஸேவும் அதுல இருந்து வருமா? அப்போ ஷார்ட் நோட்ஸ் எல்லாம் இதுல இருந்து வருமா? மைக்காலஜி இருந்து வருமா? ஆ ஓகே. இன்னும் 2 அப்ளைடா? ஓ ப்ரோ, இது மலேரியாக்கு அப்புறம் எந்த எஸ்ஸே ப்ரோ வரும் மோஸ்டா? மோஸ்ட் இம்பார்ட்டண்டா தெரியுற மாதிரி. கலாசாரம் இதுவுமா? மலேரியாவா? மலேரியாவும் லீஷ்மேனியாவா? ஓகே. ஆ ஸோ அதுதான் ஆன்டிசிபேட் பண்றீங்களா? ஓகே, பார்த்துக்கலாம். சரி, பாய். Bruh. Yo.
Who's the most attractive girl in this bar right now? Most attractive girl in this bar right now? Hey, we're on a mission. Who's it? My friend said you're the prettiest girl in this bar. What are you rating 1 to 10? An 8. Will you give me a kiss right now? Yes. Good. You're on TikTok. Hey. She said 8. She said yes. Why not? Hey, is it your girl or is it his girl? Hey. You said you would. You said you give him a kiss. Who's the most attractive girl in this bar right now?
Hell no. For the streets, dog. But it's fun, bro. Some fun shit. Yo. Sensational. It's whack. Brother.
Hi, everybody, and welcome to our module on malaria. So malaria is very high yield for your boards, and you need to know a bit more about it than the other protozoas. So that's why we have our own separate module here. So first of all, let's define malaria. Malaria is a protozoal infection caused by a protozoa called Plasmodium, and it's an infection of red blood cells and the liver. And it's very rare in the United States and in Europe. It usually occurs in places like the tropics and the subtropics. And it's high yield to remember that Africa is the most affected continent. And the reason you should remember that is because in a board question, malaria is usually going to be someone who returns to the United States after a trip to Africa. The way you get infected by this protozoa is from a mosquito bite. The female Anopheles mosquito bites you and then transmits the protozoa into your skin and blood via its saliva. As I said before, the name of the protozoa that causes malaria is Plasmodium, and there are a couple of different species, and the malaria from each species has distinct features. So Plasmodium vivax and ovale cause malaria with one set of features. Plasmodium malariae causes malaria with one set of features. And then the most dangerous form of malaria is caused by Plasmodium falciparum, and we'll talk about that in a little bit. So you need to know something about the life cycle of malaria for step one, but the life cycle is complex and you can get easily bogged down in the details. So what I'm going to do is walk you through the life cycle, and then I'll give you a couple of key points that you can remember. So the way a malaria infection starts is with the bite of the female Anopheles mosquito, and then the saliva transmits the protozoa into the bloodstream, and from there it goes to the liver. And the form of Plasmodium that transmits from the mosquito into the bloodstream is called the sporozoite form. So that's the protocol, and then I'll give you a couple of key points that you can remember. So the way a malaria infection starts is with the bite of the female Anopheles mosquito, and then the saliva transmits the protozoa into the bloodstream, and from there it goes to the liver. And the form of Plasmodium that transmits from the mosquito into the bloodstream is called the sporozoite form. So that's the infectious form, the sporozoite. And once it goes to the liver, it's going to live there for about a month, and the patient's going to be asymptomatic. So it's high yield to remember this. Someone may come back from Africa and not get sick for several weeks, and that's because the protozoa is living in the liver, getting ready to cause disease. What happens to the sporozoites when they get to the liver is that they invade the hepatocytes, and inside of hepatocytes, they mature into multinucleated cells called schizonts. So a schizont is a form of the protozoa that contains many nuclei, and it's getting ready to rupture into lots and lots of little daughter cells, but it hasn't done so yet. So it's a big cell containing lots of nuclei. And this is called the pre-erythrocytic stage because the protozoa is living in the liver and it hasn't reached the red blood cells yet. And remember that this stage is usually asymptomatic, so patients don't know that they're infected. Eventually, those schizonts will rupture. And like I said before, when they rupture, they're going to form lots of little daughter protozoa cells. And those daughter cells are called merozoites. And these are the cells that leave the liver, go into the bloodstream, and invade the red blood cells. And once they invade red blood cells, it becomes called the erythrocytic state. Inside the red blood cell, they form another stage called the trophozoite stage. And the reason this stage is important is because this is the stage that you can see when you look at peripheral.
Man, how many? Sporozoite, schizont, merozoite, trophozoite.
Blood smears under the microscope. The trophozoites look like little rings, and we'll see some pictures of those later. Inside the red blood cells, the trophozoites mature to schizonts, just like what happened in the liver. And when they do this maturation inside of red blood cells, they are digesting red blood cell proteins, especially hemoglobin. And the breakdown products are toxic to the red blood cells, so this is how they cause disease. Eventually, merozoites are formed again from the schizonts, and this lyses the red blood cells. And this process of forming schizonts and lysing the red blood cells and releasing merozoites occurs at regular intervals, 48 hours or 72 hours. It depends on the type of infection that you have. And this is why patients with malaria get cyclic fevers. Their fever spikes every 48 or 72 again from the schizonts, and this lyses the red blood cells. And this process of forming schizonts and lysing the red blood cells and releasing merozoites occurs at regular intervals, 48 hours or 72 hours. It depends on the type of infection that you have. And this is why patients with malaria get cyclic fevers. Their fever spikes every 48 or 72 hours as the schizonts are rupturing the red blood cells and releasing merozoites into the bloodstream. So here's some of the key points to remember. The protozoa goes to the liver right after the mosquito bite, and the sporozoites are the infective form that's transmitted from the mosquito to the bloodstream. There's an incubation period of about a month where people are asymptomatic. Eventually, merozoites are released from the liver and they infect the red blood cells, and this is what leads to symptoms. Plasmodium matures and grows inside the red blood cells, and eventually those cells rupture and release merozoites again. And this cycle of maturation and release is what leads to the cyclical fevers. So here's a picture of the life cycle of Plasmodium, and you don't need to know all the details on this slide, but let me just walk you through it so you understand how what I just told you fits into a picture like this that you might find in some of your textbooks. So step one is the mosquito taking a blood meal and injecting that infectious form, the sporozoite form, into the blood. From there, it goes to a liver cell where it matures into a schizont, and then the schizont ruptures and releases those merozoites into the bloodstream. The merozoites infect the red blood cells and form those ring stages that we're going to see pictures of in a little bit. Those are called trophozoites. And then it matures into another schizont, and the schizont ruptures again and releases more merozoites, which can infect more red blood cells. And this cycle over here going around and around is what causes the cyclical fever pattern. So let's talk about some of the common symptoms caused by this life cycle of the protozoa. The first classic symptom is paroxysms of fever. So people with malaria have shivering and chills followed by a high fever. It's often occurring at regular intervals like 48 hours and 72 hours. We'll talk about this later. This is variable depending on which species of Plasmodium has caused the infection. Anemia is going to be a classic symptom of malaria, obviously, because those red blood cells are being destroyed by the infection. The severity varies by species of Plasmodium, and it can be a hemolytic anemia and sometimes lead to symptoms of jaundice. So people with malaria can develop yellowing of the skin. The spleen is often enlarged because it's trying to clear those infected red blood cells. And then finally, there are lots of non-specific symptoms of malaria, things like fatigue and malaise, headache and arthralgias. Sometimes there's cough or vomiting or diarrhea. Rarer symptoms of malaria are things like altered consciousness, especially when febrile. The high fevers can make people disoriented and confused. Also, we'll talk later about how certain forms of malaria can cause capillary occlusions. You can see seizures. There's something called black water fever. This is patients who have renal failure with hemoglobinuria. So the hemoglobinuria makes the urine very dark, and that's why it's called black water fever. Malaria can cause shock, and most of the severe symptoms are due to Plasmodium falciparum. Remember, this is the worst form of malaria to have, and we'll talk about why in a little bit. Now let's talk about the different species of Plasmodium and what's unique about infection with each type of protozoa. So Plasmodium vivax and ovale you can think of together because both of these species of Plasmodium cause the same symptoms and clinical picture. So these two Plasmodium classically have a 48-hour cycle of fevers. It's called a tertian fever pattern because the fever occurs on day 1 and day 3, but there's no fever on day 2 and day 4. And a very important thing to remember about infection with these two types of Plasmodium is that they have a dormant form in the liver. They have a form called the hypnozoite form, which can live in the liver for a long time, and people can have recurring infection months after resolution. It's for this reason that people with malaria are almost always treated with Primaquine, because Primaquine is the one drug that treats. The thing to remember about infection with these two types of Plasmodium is that they have a dormant form in the liver. They have a form called the hypnozoite form, which can live in the liver for a long time, and people can have recurring infection months after resolution. It's for this reason that people with malaria are almost always treated with Primaquine, because Primaquine is the one drug that treats Plasmodium vivax and ovale liver disease. It doesn't treat the active form in the red cells, but it does treat the liver form. And so if you fail to give someone Primaquine, then they'll have a relapse many months later because that dormant form was sitting in the liver and has reemerged. The only thing you need to remember about Plasmodium malariae is that it has a 72-hour cycle of fever. So there's a quartan fever pattern with fever on day 1 and day 4 and no fever on day 2 and day 3. So the last Plasmodium species is Plasmodium falciparum, and this is the most severe form of malaria infection. The fever pattern for this Plasmodium is irregular. So there isn't a 24 or 48 or 72-hour pattern. It is irregular. And one thing that's very high yield to know for step 1 about this type of Plasmodium is that it invades red blood cells of any age. The other forms only invade reticulocytes, and that's why they cause less severe symptoms. But you can imagine that if this malaria is capable of invading any red blood cell in the bloodstream, it can cause much more dramatic and severe symptoms. Another feature of falciparum that leads to more severe disease is the presence of sticky knobs on red blood cell surfaces. So there are knobs in red blood cells infected with falciparum that are composed of parasite proteins. Plasmodium falciparum makes something called erythrocyte membrane protein 1, which is called PFEMP1, and this goes to the surface of red blood cells, and it looks like little knob-shaped proteins. And these knobs can bind to receptors on endothelial cells. This means that red blood cells infected with falciparum are more likely to glum up and occlude capillaries. This can lead to cerebral malaria when you get occluded vessels in the brain. You can get altered consciousness and delirium and coma, and it can lead to renal failure. And this is how Plasmodium falciparum causes black water fever that I described before. The way you diagnose malaria is from a blood smear, and it's high yield to remember that you use the Giemsa or Wright stains. Remember that Giemsa in particular was created to identify malaria, and it's very good for intracellular organisms like malaria. The two things you may see in a blood smear are a trophozoite ring or a schizont. So this is a trophozoite ring. It's a little circle here inside of the red blood cell. And over here, we've got something with lots and lots of nuclei, and that is a schizont. And those nuclei are merozoites that it's getting ready to rupture and release into the plasma so that the merozoites can go on to infect other red blood cells. There are a couple of red blood cell features that make the red blood cells more or less vulnerable to Plasmodium infection. So let's talk about that now. First is the Duffy antigen. This antigen on the surface of red cells is necessary for Vivax to get inside the red cell. So if you have absence of the Duffy antigen, it is protective against this form of malaria. Sickle cells may have evolved as protection from malaria because children who have hemoglobin S have a lower risk of falciparum infection. And then finally, people with thalassemia also have less severe disease when they're infected with falciparum. That's because the parasite does not multiply as effectively as in patients who do not have thalassemia. Sickle cells may have evolved as protection from malaria because children who have hemoglobin S have a lower risk of falciparum infection. And then finally, people with thalassemia also have less severe disease when they're infected with falciparum. That's because the parasite does not multiply as effectively as in patients who do not have thalassemia. Next, let's talk about some of the drugs used to treat malaria. And the first drug we'll discuss is chloroquine. This was one of the first treatments for malaria ever developed. Chloroquine is a weak base, so therefore it accumulates in the food vacuoles, which are acidic, of red blood cell trophozoite forms of Plasmodium. It blocks an enzyme that Plasmodium needs called heme polymerase. And the reason Plasmodium needs this is because the heme portion of hemoglobin is toxic to the parasite. So Plasmodium converts this to a non-toxic form using this enzyme. There's lots of chloroquine resistance. It's mainly used in very limited areas that are called chloroquine sensitive areas. It's not used for severe infections, and it only kills the erythrocytic forms, so it won't get the liver forms. And we talked about this before, and we'll talk about it again, but you have to use Primaquine to treat those liver forms. And the only unique side effect to know about this drug is if you take it for long-term therapy, you can develop retinopathy and have vision problems. The malaria drugs other than chloroquine have complex mechanisms that you don't need to know for step one. You really just need to know the names of these drugs. So for severe infections, there are two IV drugs you can use. First is artesunate and the other is quinidine. Then there are some other oral drugs that are commonly used to treat malaria. One of them is called mefloquine. This is used in areas where there's lots of chloroquine resistance. This is commonly given as prophylaxis to travelers. I took this when I went to Costa Rica, and it has one unique side effect that I remember very well. It gives you very vivid dreams. These are bizarre and unusual. And if you ever have to take this for prophylaxis, you'll never forget it. Another oral drug for malaria is Primaquine. And as I said before, the most important thing to know about this drug is that it treats the liver phase of Vivax and Ovali. It's not active against the red blood cell phase. And Primaquine is often given together with another drug in order to treat the liver phase, and the other drug will treat the red blood cell phase. And then finally, there's a drug called atovaquone that's often used for malaria as well. If you practice medicine in the United States, it's very unlikely you'll see any of the malaria drugs used to treat malaria, and that's because malaria is very uncommon. Where you will sometimes see them used is in autoimmune disease to suppress the immune system, and that's because both chloroquine and hydroxychloroquine have immunosuppressive actions. Their mechanism of action to suppress the immune system is not clearly understood, but they have been shown to block toll-like receptors in B cells, which leads to decreased activation. In addition, they are weak bases, and they raise the pH in immune system cells, and it's believed that this makes them less active. There are also many other actions that have been described for these drugs. So you will see many patients on these drugs, particularly on hydroxychloroquine. It also goes by the name Plaquenil, and you will see patients taking that for rheumatoid arthritis and sometimes for lupus. The last thing I want to mention in this module is of G6PD deficiency. This is an X-linked genetic disorder. It's relatively rare, but it results in hemolytic anemia that's triggered by various stressors. And classic stressors are certain infections, fava beans, and many drugs. And you should know that many malaria drugs trigger anemia in G6PD. In particular, Quinidine and primaquine can both trigger anemia in G6PD. So patients are often tested for a G6PD deficiency prior to treatment. So for example, if you're going to give primaquine to treat the liver phase of Vivax or Ovali, you will often test for this disorder. If you're going to give IV quinidine for life-threatening falciparum infections, you will also test for G6PD deficiency first. And that concludes our module on malaria.
What is the vector for malaria? Anopheles, mosquito. What is the most dangerous type of malaria? Is caused by Plasmodium falciparum. When a female mosquito bites, it transmits what form of Plasmodium? It sporozoite. Sporozoite. When sporozoite or Plasmodium enters the blood, where do they travel? They travel to the hepatocytes, liver, into multinucleated schizons. When Plasmodium ruptures, it releases. When Plasmodium schizont ruptures, it releases merozoites. What form of malarian had existed in RBC before trophozoites? Inside RBC matures into schizont, trophozoite. What cell type does sporozoite form? Infect hepatocytes. What form is Plasmodium in when it ruptures from hepatocytes? The schizont, sporozoites, merozoites. When Plasmodium schizont rupture, what do they release? Merozoites. How long is incubation period of malaria? Maybe a month. Which form of malaria displays a ring form on microscopy? Falciparum. Oh, which form of trophozoite? Trophozoite present. Trophozoite turns into a schizont. Malaria causes what kind of fevers? Causes like chilling, cyclic fevers. Okay. Which Plasmodium species have a 48 Vivax rovale? Have a 72 is malaria. Plasmodium malariae. P has hypnozoite from Vivax rovale. What is the fever of falciparum? Irregular. Dash blocks Plasmodium heme polymerase, chloroquine. Which drug blocks chloroquine? Which drug is used to treat hypnozoite form of primaquine? Which stage of life is shown below? Trophozoite. Plasmodium malariae has a 72-hour fever pattern. Vivax and ovale have a 48-hour fever pattern. Can cause cerebral falciparum. Travel with the Anopheles mosquito. There is a mature state of malaria and the hepatocytes or schizont. Which stage invades which stage in malarial life cycle? Merozoite. Are infectious form of malaria? The sporozoite. Liver form of P. vivax and ovale, primaquine, chloroquine. Caniston blocks heme polymerase. Severe infection, you have atropine, primaquine, quinidine, artesunate, quinidine are used for severe artesunate and quinidine. When there is chloroquine resistance, you use prime tovacone, proguanil, mefloquine. Oh yeah, those three using chloroquine is mefloquine, tovacone, and proguanil. Again, this is ectocyphone primocane. When Plasmodium schizones rupture, they release neurocytes, which turns into a schizone. Dormant in the liver form is a hypnocyte form. Total impoundable tovacone, proguanil, and mefloquine. This shit is easy, bruh. This should be too easy, bro. Should be too easy, bro. Oh, bro. Oh, really? I'm down. I'm done.